Sarcoidosis. Sarcoidosis is a multisystem inflammatory disease of unknown etiology that predominantly affects the lungs and intrathoracic lymph nodes. Sarcoidosis is mainly manifested by the presence of known caseating granulomas in affected organs and tissues. Modern history of sarcoidosis. In 1899, the pioneering Norwegian dermatologist Caesar Boeck describes skin nodules characterized by compact, sharply defined foci of epithelioid cells with large pale nuclei and also a few giant cells. Thinking this resembled sarcoma, he called the condition multiple benign sarcoid of the skin. Epidemiology. It usually affects all types of racial groups, ethnic groups, all ages, with the incidence peaking at 20 to 39 years of age. It has more effect in males than female by the ratio 2:1. The incidence, highest annual incidence in northern European countries is 5 of 40 by 1 lakh. In Japan, the annual incidence is 1 of 2 by 100,000. Among black Americans is roughly 3 times that among with Americans, 35,500,000 as compared with 10.9 per 100,000. Pathophysiology. T cells play a central role in the development of sarcoidosis as they likely propagate an excessive cellular immune reaction. The cause of sarcoidosis is unknown. Efforts to identify a possible infectious etiology have been unsuccessful. Genetic and environmental factors seem to play a major role. As yet, no bacterial, fungal, or viral antigen has been consistently isolated from the sarcoidosis lesions. Sarcoidosis is neither a malignant nor an autoimmune disease. The following have been suggested as possible candidates that might play a role in causing sarcoidosis. Mycobacteria, such as Mycobacterium tuberculosis, and atypical pathogens have been suggested. Fungi and viruses, particularly Mycoplasma, Chlamydia, and Epstein-Barr virus, that is EBV, have been unconvincingly implicated. Environmental causes. Some of the earliest studies of sarcoidosis reported associations with exposures to irritants found in rural settings, such as emissions from wood-burning stoves and tree pollen. More recently, associations with sarcoidosis and exposure to inorganic particles, insecticides, and moldy environments have been reported. Occupational studies have shown positive associations with service in US Navy, metalworking, firefighting, and handling of building supplies. Genetic features. Familial sarcoidosis was first reported in 1923 in 2 affected sisters. No formal twin study has been reported, but the concordance appearance to be higher in monozygotic twins than in dizygotic twins. In a case study control study, patients with sarcoidosis stated 5 times as often as control subjects that they had siblings or parents with sarcoidosis. Some common clinical features as can be seen. Presentation depends on the extent and severity of the organ involved. Approximately 5% of cases are asymptomatic and incidentally affected by CXR. Systemic symptoms occur in 45% of cases, such as fever, anorexia, fatigue, night sweats, weight loss, etc. Pulmonary dyspnea on exertion, cough, chest pain are some of the common features too. Lofgren's syndrome, an acute presentation consisting of fever, arthralgia, erythema nodosum, bilateral hilar adenopathy, occurs in 9 to 34% of the patients of sarcoidosis. Hereford syndrome, anterior uveitis, fever, parotid enlargement, facial palsy. Physical finding. Pulmonary findings, dermatological manifestations, ocular manifestations, cardiac manifestations, and neurological manifestations are rarely seen. Organ involvement. Sarcoidal granulomas can involve any organ, but in more than 90% of patients, clinical sarcoidosis is manifested as intrathoracic lymph node enlargement, pulmonary involvement, skin or ocular signs and symptoms, or some combinations of these findings. Pulmonary involvement. Dyspnea, cough, vague chest discomfort, and wheezing are some of the normal chest findings that we find with the patients of sarcoidosis. Chest radiographs in patients with sarcoidosis have been classified into 4 major stages. First, stage 1, bilateral hilar lymphadenopathy without infiltration. Second is bilateral hilar lymphadenopathy with infiltration. Third is infiltration alone. And stage 4 is fibrotic bands, bullae, hilar retraction, bronchiectasis, and diaphragmatic tenting. These so-called stages represent radiographic patterns and do not indicate disease chronicity or correlate with changes in pulmonary functions. As you can observe, stage 1, stage 2, stage 3, and then there is cutaneous involvement. Although not life-threatening but can be emotionally devastating, erythema nodosum may occur. Lupus pernio is the most specific associated cutaneous lesion. Violaceous rash is often seen on the cheeks or nose. Osseous involvement may be present. Maculopapular plaques are also possibly seen. Liver and spleen involvement. 10% of all patients with sarcoidosis have elevated serum aminotransferase and alkaline phosphatase levels raised. A cholestatic syndrome characterized by pruritus and jaundice, hepatic failure, or portal hypertension can develop due to renal liver involvement and is usually clinically silent. Detection of hepatic and splenic lesions on CT is described in 5% and 15% of patients. Neurologic involvement. CN is involved in up to 25% of patients with sarcoidosis who undergo autopsy, but only 10% of all patients with sarcoidosis present with neurologic symptoms. The most common problems are cranial nerve palsies, headache, ataxia, cognitive dysfunction, weaknesses, and seizures. CSF analysis, non-specific lymphocytic inflammation measuring ACE levels. Oligoclonal immunoglobulin bands in the CSF are also elevated. Ophthalmologic complications. The eye and adnexa are involved in 25 to 80% of patients with sarcoidosis, this necessitating routine slit lamp and fundoscopic examinations are used. Anterior or posterior granulomatous uveitis can occur. Conjunctival infections and lesions, scleral plaques may also be noted. Cardiac manifestations. Heart failure from cardiomyopathy rarely occurs. Heart block and sudden death may also occur. Approximately 25% of patients may have NCGs at autopsy, but fewer than 5% have clinical cardiac disease. Differential diagnosis. Hilar infiltrates, tuberculosis, lymphoma, eosinophilic granuloma, fungal infection, lung cancer. NCG on a biopsy, berylliosis, cat scratch disease, fungal infections, hypersensitivity pneumonitis, leprosy, primary biliary cirrhosis, tuberculosis. Diagnosis. The diagnosis is established on the basis of clinical finding, radiological findings, supported by histologic evidence in one or more organs of non-caseating epithelioid cell granulomas in the absence of organisms or particles. A diagnosis of sarcoidosis is reasonably certain without biopsy in patients who present with Lofgren's syndrome. Laboratory studies. Routine lab evaluation often is unrevealing. Hypercalcemia or hypercalciuria may occur. NCGs secrete 1.25 vitamin D. Hypercalcemia is seen in about 10 to 13% of patients, whereas hypercalciuria is 3 times more common in patients of sarcoidosis. An elevated alkaline phosphatase level suggests hepatic involvement. Angiotensin converting enzyme levels may also be elevated. NCGs secrete ACE, which may function as a cytokine. Treatment. Most patients, that is from more than 75% of patients, require only symptomatic therapy such as NSAIDs. Approximately 10% of patients need treatment for extrapulmonary disease and 15% of patients require treatment for persistent pulmonary disease. Corticosteroids are the mainstay of therapy. Prednisone given daily and then tapered over a 6-month course is adequate for pulmonary disease. Earlier recommendations suggested an initial dose of 1 mg per d of prednisone. However, more recent expert opinions endorse a lower dose, which is tapered to every other day long-term therapy over several weeks. Most patients who require long-term steroids can be treated using 10 to 15 mg of prednisone every other day. High-dose inhaled corticosteroids may be an option, but conclusive data are lacking. For pulmonary disease, asymptomatic PFT and chest X-ray abnormalities are not an indication of treatment. In patients with minimal symptoms, serial re-evaluation is prudent. Significant respiratory symptoms associated with PFT and chest X-ray abnormalities likely require therapy. For such patients, treatment is indicated if objective evidence of recent deterioration in lung function exists. Prognosis. Many patients do not require therapy and their conditions will spontaneously improve. Markers for a poor prognosis include advanced chest X-ray stage, extrapulmonary disease, evidence of pulmonary hypertension, and multiple studies have demonstrated that the most important marker for prognosis is the initial chest X-ray stage. Death. Less than 5% of patients die from sarcoidosis. That is usually the result of pulmonary fibrosis with respiratory failure or of cardiac or neurological involvement. Thank you.